Hi, my name is Emily Kline. I'm a psychologist at Boston Medical Center and an assistant professor in the Department of Psychiatry at Boston University School of Medicine. I'm going to be presenting at the CTSI conference on my poster, which describes a clinical trial that I did of an intervention called Motivational Interviewing for Loved Ones. I want to start with some background about the population in this trial. So I work with a lot of young adults and adolescents who are experiencing their first episode of psychosis. This is characterized by psychotic symptoms such as hallucinations, delusions, and disorganized behavior, as well as negative symptoms like reduced functioning, reduced socializing, basically kids who are really struggling both to manage their experiences that are happening in their mind and to function as they used to in roles like friendship in school. Psychotic disorders like schizophrenia and bipolar disorder usually emerge in adolescence or early adulthood. And this first episode of psychosis is a critical window to engage these young people in treatment, take care of their psychotic symptoms, and help them get back on track developmentally so that they can go on to college, careers, relationships. There's a lot of research showing that family involvement in first episode psychosis treatment leads to better outcomes, and that's for a few reasons. Number one, most of these kids are either living with their parents or return home in the context of their symptoms, and the parents are the ones who are usually initiating the treatment, bringing them to appointments, picking up prescriptions, trying to get their kids to do the right things, because sometimes the young adults themselves are not thinking clearly. And also because we have research showing that family environments that are low in stress are better for recovery. So I work with a lot of parents and families of these adolescents and young adults, and they're always wondering what they can do, the parents can do, to both create a less stressful home environment and encourage their kids to engage with treatment. Motivational interviewing is a really useful therapeutic toolkit. It's an evidence-based style of therapeutic communication, and it's just a way of talking about change without making people feel condescended to or defensive. And it's been used with good research evidence in the field of addiction for a long time. So the idea that I had was to develop a brief motivational interviewing training program for parents or other family caregivers of adolescents and young adults experiencing a first episode of psychosis. And the aim of this study was to investigate the impact of participating in this brief training in a group of family caregivers relative to a group that got on a wait list. This was a randomized controlled trial, meaning that every time a family caregiver enrolled, we would consent them to the study, conduct a series of assessments, and then randomize them to one of two conditions. Both groups ended up receiving the intervention, but one group received the intervention right away, which was a 5-hour psychoeducational training with a therapist, and the other group waited for 6 weeks before they too received the training. This is called a crossover design, meaning that everybody in the end got the training, but we can see at that 6-week time point what the impact was of getting the intervention versus being on a wait list. This is a busy slide, a lot to show here. So first I want to look at this Prisma flow diagram, which is a way of showing data in clinical trials. We had 46 people who inquired about participating in the study and were assessed for eligibility. 40 of them did meet the eligibility criteria and completed the baseline assessments. 19 were randomized to waitlist and 21 to immediate intervention. The reason that those numbers are uneven is that some people participated in pairs. So like a mom and a dad would want to do the intervention together. So we randomized them together. We had really good retention in the study. Almost everybody completed all 5 sessions and completed their follow-up assessments. So in the end, we had, I think, 38 people who did at least one post-intervention assessment. We also followed up with people after they got the intervention or after they were on the wait list. For the people who were on the wait list, we did another set of assessments after they got the intervention. Then we followed up with people again 8 weeks later and 12 weeks later to see if the differences and the improvements that they experienced from participating in this intervention were durable, if they lasted beyond when they had last seen us. Participant characteristics, we had 40 participants. I'm going to zoom in so it's a little bit easier to see. Oh, that's too much. Okay. Participant characteristics of the 40 participants, a wide range of ages, from 28 to 80, and that's because it wasn't just parents. We had some siblings and some grandparents as well, but everyone identified as a primary caregiver of this individual experiencing psychosis. The average age was 58. Most of the participants were women. I think that really reflects that women in this country do the vast majority of unpaid caregiving when a family member gets sick. As I said, most of them were parents, but we had a couple of grandparents, one grandparent went on, and a couple of siblings. Most of them said they were living with the individual with psychosis. And in terms of race, it was a mostly white sample and mostly college educated. I want to tell you a little bit more about the intervention itself. So the core skills that we taught them were sort of the philosophy or spirit of motivational interview. We talked a lot about resisting that urge to jump in and try and offer solutions or fix another person's problem right away, which is a core part of that philosophy of motivational interviewing. So we talked about this settings in which caregivers feel compelled to jump in and say, well, why don't you just take your medication? Or can't we just see a doctor about this problem? Which is an understandable urge. But the technique of motivational interviewing is to resist doing that right away and instead kind of explore the person's ambivalence by doing good reflections and asking questions, and then and only then giving advice if it's needed. So I taught parents how to do reflections, taught them how to ask good questions, how to try and move toward problem solving in a conversation, and just how to kind of raise difficult topics like, I really want you to take a medicine for this thing that you're going through, when that can be really awkward and bring up a lot of anxiety for families. We also talked about giving advice, when you give it and how to give it, and the nice technique of sort of asking permission or saying, I have some ideas that I think might help you. Would you like to hear them? So in session 1, we talked about their family dynamic. I answered any questions about psychosis that they had, and I started to introduce the concepts of motivational interviewing. In sessions 2 and 3, we really focused on the core skills of motivational interviewing. And in session 3, I helped them put it all together, and we would role play different conversations that they wanted to have. Sessions 4 and 5 were a little more open-ended. I would talk to the families about whether they had tried the techniques, what happened, and if they wanted to continue role-playing to practice. Table 3 is showing a regression comparing those who got the intervention right away to the control waitlist condition. And this is only outcomes at the 6-week time point, but we already see detectable, statistically significant effects on family conflict and expressed emotion, which is a construct that really reflects the level of stress in the caregiver and in the household. So those are really positive results. I saw trend level results for parent stress and no result at the 6-week time point for another outcome I was interested in, which was parents' sense of self-efficacy, their sense of I'm doing a good job at being a caregiver. This chart, as I said before, everybody did eventually get the intervention, which allows a little more statistical power to put all 40 participants together and look at effects over time. And what we saw was really large and statistically significant and durable effects that occurred at the 6-week time point, but also after. So durable means that they didn't kind of go back to their baseline when I hadn't talked to them for 12 weeks. You can see that their self-efficacy improves and stays improved. Their expressed emotion decreases and stays decreased. Stress decreases and stays decreased. and conflict decreases and continues to decrease over time. A little bit more information about the youth themselves. They were relying on their parents quite a bit, per the family caregivers report. Family caregivers reported that they were providing emotional support, instrumental support, meaning finances and transportation and housing. They were offering information and advice to their ill family member, and they were also specifically assisting with medical appointments. Of those, in terms of the youth and the young adults with mental illness, most of them had, oh, it's not on the slide, but most of them had schizophrenia or schizoaffective disorder. Some had bipolar disorder, or what we call an unspecified psychotic disorder. So again, I think that the results really show that this brief intervention was effective for the family caregivers. They really liked it. They hung in there with the study. They didn't drop out. They had significant effects on family climate, conflict, and the outcomes were actually larger than expected. What I didn't find was any detectable effects in terms of the youth's participation in treatment. I wasn't measuring that particularly well, but I hope to do another study where I can look at that more directly and see what impact the parents participating or the family caregiver participating in an intervention like this may have had on the youth with the mental illness itself. That's all my slides. Happy to answer questions at the actual conference. Thank you for your interest, and feel free to get in touch with me. Again, my name is Emily Kline, Kline. You can find me, Emily Kline, at bmc.org. Thanks.